Thank you very much for the kind invitation to speak today. So, just some disclosures to start with. We've have received some ongoing research support from industry, and also have several patents pending pertinent to antibodies that were discovered at Mayo Clinic, some of which we'll discuss today. And we work with industry across a number of different domains, whether it's looking at new diagnostic kits or working on clinical trials for the treatment of autoimmune central nervous system diseases such as NMO, autoimmune epilepsy, and autoimmune encephalitis. So the other thing to mention that we always do for talks where people are getting CME points is to talk about any off-label treatments. And as you are probably aware, autoimmune movement disorders are very rare diseases, so we don't have class 1 evidence to support treating these, and so basically all the treatments are off-label. So the learning objectives are to review the spectrum of autoimmune movement disorders, review the biomarkers pertinent to autoimmune movement disorders, and review where autoimmune movement disorders fit in the overall context of testing for autoimmune CNS disease. So I'm going to try and use autoimmune movement disorders not just to tell you about the disorders themselves and the antibodies, but also for this to kind of serve as a paradigm for our approach to the evaluation, diagnosis, and management of patients with these diseases. And here are some of my colleagues that I work with at Mayo across 3 different Mayo Clinic sites. So there are a number of people who work in the lab with me, such as John Mills and Sean Piddock, who co-direct the lab, and then a number of other consultants. So we're called consultants at Mayo Clinic rather than attendings. Goes back to an old English tradition. So our consultants here, Dr. Lennon, who founded the lab, and then a number of people who work in neurology, faculty positions in autoimmune neurology across the 3 sites. So Sebastian Lopez in Florida, Cristina Valencia Sanchez in Arizona, Mayo Clinic, Arizona, and Phoenix. And also Nick Zaleski is working there too in the same practice. And then we have a number of other people who've contributed to some of the work I'll discuss today, either test development staff or research fellows. So what is the autoimmune movement spectrum? Well, it's really the same as the movement spectrum. So the spectrum of movement disorders is listed out here, and autoimmunity has been described in the context of all of these different phenotypes. But I wouldn't want you to leave the talk today thinking that every time you see a patient with a movement disorder that you need to be ordering evaluation. So there are very specific scenarios and phenotypes where this type of testing becomes relevant. So what are antibodies and how are they relevant? So you have a neurological disorder, you have autoimmunity suspected, so immune response against self. So a common autoimmune disease is autoimmune thyroid disease, where you have an immune attack on the thyroid gland, or type 1 diabetes, where you have an immune attack on the endocrine components of the pancreas, the insulin secreting beta cells. But in neurological disease, there is also the concept of autoimmunity and an immune attack on the nervous system. So this is a little distinct from multiple sclerosis or sarcoidosis, where there is inflammation in the nervous system, but not necessarily an antigen-specific immune response. So by antigen, I mean protein. So an example in the world of neurological autoimmunity would be aquaporin 4, or the water channel pertinent to neuromyelitis optica, or NMO. So that distinguishes autoimmune neuromyelitis optica from chronic inflammatory multiple sclerosis. So what are antibodies? These are basically robust molecules that are detected in patients with these diseases, with these autoimmune diseases. And in some cases, the antibodies may be causative of disease, binding to receptors or water channels and downregulating them and causing their destruction, or activating complement and causing inflammation. But sometimes the antibodies are not pathogenic, they're not disease causing, but they're still very good biomarkers of what's going on. but they may be indicative more of a T cell response against the same antigen. So that's kind of that in summary. And essentially the ones where we're thinking the antibodies might be pathogenic are generally against cell surface receptors on the surface of neurons or on the surface of glial cells. And sometimes these patients respond to just antibody depleting therapy like plasma exchange. And then you may have reversal of this whole process where the receptor gets back on the cell surface and functions again over time. But then on the other hand, you may have a kind of a classical paraneoplastic disorder whereby you have an antibody biomarker of a T cell mediated process against HU, which is ANA1, against YO, which is PCA1 antibody, against CRIM5 or MAT2. A lot of the time, these patients have an occult cancer, and that would be the main target of treatment. And often these patients are not immunotherapy responsive. So those are kind of two broad groups of antibodies. So in the laboratory, how do we screen for these? So you'll see a number of instances today of tissue-based indirect immunofluorescence. So this is kind of a broad screening tool for autoantibodies based on the staining characteristics of mouse brain that the patient's antibodies produce. Then there are cell-based assays or immunoprecipitation assays, Western blots, ELISAs, and these are all really antigen specific. And so you have your protein, you have your antibody, you have binding, and then you have a readout. But essentially it's positive or it's negative. And so those are often complementary to our tissue-based assay, either for confirming the presence of a specific antibody. So we see the tissue staining pattern and then we reflex it to one of these assays. Or in some instances, these assays may be better for detecting that particular antibody. So for example, aquaporin 4 and MOG antibodies who don't pick up very well on tissue, but we do pick them up very well on a cell-based flow cytometry assay. So we could start kind of walking through kind of maybe an example of an autoimmune neurologic disease and we can address kind of a number of paradigms by looking at this. And a lot of this is just broadly applicable to other disease states. So back in the 1980s, the PCA1 or anti-YO antibody was described and was associated with cerebellar degeneration in women with either a gynecologic or breast cancer. So these women would present not with cancer, but with a profound neurologic disorder with very severe incoordination, imbalance, and ultimately becoming walker or wheelchair dependent. And in that setting, it would be found that the patients would have an occult cancer. And ultimately, it was found that these patients had an autoimmune disease with an antibody that's reactive and T cells that are reactive with both this YO protein in the tumor, but also this protein in the nervous system. So you get the appropriate response against the tumor, but then this patient probably has an autoimmune tendency, and then for whatever reason you get that immune response turning on the same protein in the nervous system, and then you get the cerebellar degeneration. So this is an example, kind of a classical paraneoplastic disorder. And so these patients typically don't do well, maybe will stabilize with the removal of the tumor, but generally end up with quite a lot of disability. And so when you'd read textbooks, up until quite recently, if you were asked about, autoimmune cerebellar ataxia in a paraneoplastic setting, this is the first one people would say, and that might be the only one that they would say. They would not know of other instances. But in fact, over time, it's really been built out that there are a number of other autoantibodies associated with ataxia, and these are all listed here. And these autoantibodies may be associated with other neurological presentations, but there are patients who presented with these kinds of problems. Here's an example here. So here's a So you can hear her ataxic dysarthria. And she has kind of a milder cerebellar phenotype than what I just described. But it was quite subacute in onset, and so the suspicion was this is potentially an autoimmune disease. So that's kind of a very characteristic kind of clinical pearl here is, if it's rapid in onset, not hyperacute like a stroke, and not insidious in onset, with progression over months, but more like onset with fairly significant progression over 6 weeks or so, then you're kind of in that sort of ballpark of where we should be thinking about an autoimmune causing the differential diagnosis. So she actually had mGlu1 antibody, and this is kind of a sort of an approach that we would take in the lab to look for various antibodies associated with ataxia. So this is the mGlu1 antibody staining pattern here, and we can then reflex it to kind of a cell-based assay to confirm that that's what it is. But as you can see, there are multiple other staining patterns that are associated with antibodies relevant to cerebellar ataxia. So we could do our tissue IFA, look for the particular staining pattern, reflex it to a particular antibody to confirm that specificity if the tissue criteria are met. And then we can send out a report saying we detected mGlu1 antibody or whatever it might be, and we know that this is associated with cerebellar ataxia, or with autoimmune cerebellar ataxia. And for some of these antibodies, there may be a cancer association. So, for example, mGlu1 is associated with Hodgkin's disease, though there are some patients, including our patient that I just showed you, who do not have a cancer found. But we can kind of tell the doctors in the report, what cancers have been found in the past in these patients and what to think of. So neuronal antibodies in general have varying levels of association with cancer. Some are very strongly associated, like ANA1 or PCA1, which are Yo and Hu respectively. And then others like Septin5, we've not found cancer in these patients. Other things that are interesting when you kind of drill down on mGlu1 antibody, and you compare patients with this particular antibody versus, say, a PCA1 case, you do see that there are differences. So as well as there being ataxia, there can be some patients who have limbic symptoms. So kind of a limbic encephalitis, memory, seizure, psychiatric symptom can coexist in these patients, or they can have loss of taste. And these might be clinical clues to those diagnoses, whereas we don't see this with PCA1 associated or Yo associated ataxia. And then the cancer profile is different, as I mentioned, lymphoma, Hodgkin's disease or non-Hodgkin's disease, and we've had a couple of cases of prostate cancer as well. Whereas the PCA1, the one I originally showed you, these are women with breast cancer or gynecologic cancer. So really kind of the point of this is that same clinical presentation, but different antibody, different cancer association, different kind of deep phenotyped associations, but then also different outcomes. So this particular lady that I showed you had a very good response to immunotherapy, and didn't have progression, remained independent in her walking, no cane or anything else required. So again, these differences do matter, and they are antibody specific. So here's another example of an autoantibody that is associated with ataxia. And this particular one, though, unlike Yo and mGlu1, was actually described at Mayo Clinic. And so this is antibodies against neuronal intermediate filaments. And there are various neurologic associations, either encephalopathy, ataxia, or myelopathy. But if the patient has this particular antibody, unlike what I just showed you, typically the cancer association would be small cell or Merkel cell cancer. With these particular antibodies, there are different antibodies that are kind of, or different subtypes of the neuronal intermediate filament antibodies that are kind of make up this profile. If we find light chain, which I've highlighted in green here, light chain antibodies, this is particularly associated with a paraneoplastic cause. But there are patients whereby we do not find a cancer, and so there are other causes that we're exploring, including tick-borne disease associations. So here are some of the cancers that are associated with the neuronal intermediate filament antibodies. So these are really the common theme here really is neuroendocrine lineage. And so small cell, Merkel cell, skin, and then pancreatic, these are all neuroendocrine lineage. And then another one discovered at Mayo that we will be, the neuronal intermediate filaments is already live, but the septin-5 antibody will be going live next year in our movement evaluation. The only association we found with this particular antibody is cerebellar ataxia. So unlike the mGlu-R1 or the PCA1 or the neuronal intermediate filament antibodies, this particular one so far we found is associated with cerebellar ataxia. So again, this is highly predictive of that particular disorder. And some of these patients do respond to immunotherapy also. One that has also gone live that is associated with an ataxia-like disorder, but generally this is kind of more of a brainstem encephalitis. So you're seeing not just kind of a pure cerebellar disorder whereby you get incoordination, nystagmus, dysarthria, gait problems. In addition, with protein 11 antibodies associated with seminoma, you also can see other features of a brainstem encephalitis, so double vision, vertigo, hearing loss in particular seems to be associated with that, swallowing, speech problems. So that's cerebellar ataxia. So I think the bottom line here is that you can see the complexity of the testing. So in the past, people have said, well, you know, if it's ataxia, it's probably I'm going to order EO. If it's limbic encephalitis or small or kind of a sensory neuronopathy, I'm going to order HU. But you can see that there's really kind of a complexity to kind of the biomarkers that are associated. So we realize that this is more like genetic testing now, and that there's just such a potpourri of different disorders and antibodies that really all we really should be asking clinicians to do is say, broadly speaking, what phenotype is this? And then, you know, is this kind of subacute onset with rapid progression that would make me suspicious for an autoimmune cause? And then you would order the autoimmune movement disorders evaluation, and that would include all of the antibodies pertinent to ataxia. So moving on to Parkinsonism. So these patients don't have garden variety Parkinson's disease, but they have disorders that could be potentially confused with PSP, progressive supranuclear palsy, or maybe multiple system atrophy. But when you kind of do a deep dive, phenotypically they do look different, but they tend to be, again, subacute onset. Often very severe early problems with neck rigidity, jaw dystonia, diplopia, balance problems are kind of the main features. You could argue that these are kind of a sort of a form of brainstem encephalitis, just without the ataxic component, and more of a Parkinsonian feel to the disorder with a lot of postural instability and rigidity. But there are antibodies here, and as you can see, there is some overlap. So we already mentioned GAD65 and IGLON5 as being biomarkers of autoimmune ataxia. So you can kind of see that these particular patients with these particular antibodies can have different presentations. So in this situation, a Parkinsonian or dystonic phenotype. So ANA2 is associated also with other movement disorders, opsoclonus myoclonus syndrome, sleep disorders. We mentioned laryngospasm. So with these kind of brainstem disorders where you get a lot of dystonia, either cervical dystonia, jaw dystonia, you also can get dystonia of the laryngeal muscles as well, and people can have episodes of respiratory arrest essentially. And there have been patients that we've had to place tracheostomy tubes to stop them from having recurrent respiratory arrest. But these things sometimes can be a clue to a paraneoplastic or autoimmune brainstem disorder. But other associations outside of movement disorders include limbic encephalitis. So the cancer association here is breast cancer by and large. If it's a woman with ANA2 or anti-Re antibody only, we think of breast cancer. So this next disorder, this IGLAN5 antibody, this is again to kind of try to illustrate how different antibodies can have different associated phenotypes. So I already told you IGLAN5 antibody could present with cerebellar ataxia. It could present with a brainstem disorder, as kind of illustrated here in this particular patient, who essentially has myarrhythmia. So you can see this facial contraction here, about 1 hertz. But like the previous patient, she also had some neck rigidity, postural instability, an eye movement disorder, and then also she had some jaw dystonia. So she has difficulty opening her mouth. You can also see the ongoing myarrhythmia of the jaw. So that's one presentation. So we said an ataxia, broadly speaking, an ataxic phenotype, broadly speaking, more of a Parkinsonian dystonic phenotype. And then thirdly, a patient with a subacute onset chorea. And so frequently these patients with a choreiform presentation often have some of the features of Huntington's disease. So as well as the chorea, they have some disinhibition, eye movement disorders, but just the rapidity of the onset and progression, the absence of family history really should raise concern for an autoimmune cause. So if you taking in terms of commonality in this age group, after Huntington's disease and levodopa-induced dyskinesias, autoimmunity is overall the commonest cause of chorea in adults. And we show that in an Olmsted County study that we did looking at chorea. But again, each individual antibody is rare. So this IGLAN5 antibody is very rare. But again, we would not suggest that you should be having to think, oh, okay, I'm going to order IGLAN5 and I'm going to order maybe CRIMP5 because that's associated with chorea. We would just say you just order the autoimmune movement disorders evaluation. So this is how we identify it in the laboratory. And so as well as looking at brain tissue, we have other reference points to make kind of our histologic diagnosis, so to speak. So we have multiple reference points within the brain, as well as having cerebellum, hippocampus, thalamus, cortex, midbrain, but then also some gut lining around the outside that has both smooth muscle components that stain here with IGLAN5, but also myenteric nerve components. And then in the kidney, we have these other components, including the glomeruli of the kidney. And so interestingly, the glomeruli of the kidney have quite a large repertoire of neural antigens, and the way that they stain sometimes can be a clue to particular antibodies like IGLAN5 and ANA3 antibody. So other antibodies associated with chorea include classically CRIMP5, ANA1, and there's our friend GAD65 antibody again. So worth mentioning, GAD65 antibody at a low titer in our lab of less than 20 nanomoles per liter is typically more commonly associated with other non-neurologic autoimmune diseases like type 1 diabetes and thyroid disease. But in neurologic disease, if we see patients presenting with ataxia or stiff person syndrome or chorea or a Parkinsonian phenotype or a myelopathy, and where the GAD antibody is greater than 20 nanomoles per liter and usually in the hundreds of nanomoles per liter, we would think of GAD neurological autoimmunity. Anyway, I digress. Back to kind of chorea. There are two broad groups, and so we cover the paraneoplastic and some of the other ones, like IGLAN5 autoimmunity. The paraneoplastic patients generally are older and male, and they may have coexisting neuropathy and are generally smokers. And so these are kind of often the sort of the small cell lung cancer associated choreas. But there are patients that are negative in our lab, but you may find that when you order lupus antibodies, phospholipid antibodies and so forth, that those patients are positive. In general, these patients with the idiopathic autoimmunity with lupus or phospholipid antibody syndrome are the ones that are very immunotherapy responsive. So here's an example of a kind of an interesting chorea dystonia that we saw. And this is just to kind of highlight, if you have a patient who has got cancer and is receiving checkpoint inhibitor immune therapies that essentially boost the T cell response against cancer, and then they develop a neurologic problem subacutely, they have a very special type of paraneoplastic syndrome whereby it's checkpoint inhibitor induced. So autoimmunity after checkpoint inhibitor drugs like PD-1 inhibitors or PD-1 ligand inhibitors can develop autoimmune complications, most commonly non-neurologic disease like thyroid disease, inflammatory arthritis, inflammatory bowel disease. But we have seen quite a number of patients in the last few years who have neurological complications of checkpoint inhibitors. So this particular lady had received a checkpoint inhibitor for metastatic renal cell carcinoma and actually had a great response to it. Was in remission from that, but she developed this hyperkinetic movement disorder. And she responded very well to, she responded somewhat to immunotherapy. In fact, I think that video there was probably her best response. But ultimately, we actually ended up treating her with a dopamine receptor blocker combined with a dopamine depleting agent. So, stiff person spectrum. So as you can see here, this lady's lying flat here on the bed, and you can see that her lumbar lordosis is not fully reduced. And what she complained of was truncal spasms, truncal stiffness, difficulty moving her back pain, difficulty moving her legs when she would walk, getting whole body spasms that would cause her to fall. You can see the limitation of her movement in her trunk when she tries to sit up. And when she's walking, she's difficulty flexing forward, as you can see. Then you can see her extensor paraspinal muscles are pulled very tight in her back. So this is very characteristic of classical stiff person syndrome with a kind of a stiff trunk predominance. And she was GAD65 antibody positive. The essence of this is that you're dealing with central nervous system hyperexcitability, and that is leading to these excessive startle responses, excessive stiffness, spasms, and a tendency towards falls, particularly when startled. There are a number of different antibodies pertinent in this situation. GAD65 at high titers in about 80% of patients, but then there are several other. Glycine receptor and amphiphysin are really the ones that are proven to be important in this particular disease state. DPPX antibody for a form of stiff person whereby the entire central nervous system and autonomic nervous system is involved, that we call PERM, progressive encephalomyelitis, with rigidity and myoclonus. So kind of a very severe hyperexcitable disorder. And that's commonly associated glycine receptor antibody, but also DPPX antibody that I failed to mention here. But really GAD65, glycine receptor, amphiphysin, and DPPX, those are really the important markers for that. So glycine receptor antibody in serum is pretty sensitive, but has some specificity issues. So we have not kind of put this into our movement disorders evaluation for that reason, because I think we would just generate a lot of positive results of unknown significance. So instead, what we've done is we've developed a stiff person evaluation that's kind of quite restricted to just those 4 antibodies. The other ones that I mentioned at the bottom really are kind of exploratory markers that haven't really hit the prime time for diagnostics in stiff person. So that DPPX antibody that I mentioned there, again, we can diagnose that by looking at kind of the particular staining tissue in the patient on indirect immunofluorescence. So this is basically mouse brain, as I mentioned earlier, with a piece of gut around the outside and a little bit of wedge of kidney as well as a control. So we expect to see staining of neural elements like the myenteric plexus here in the gut, but the rest is negative. Lots of synaptic staining in the hippocampus, the cerebellar cortex. So this is basically you're applying patient antibody to tissue, and then you're incubating and coming in with an anti-human secondary antibody that has a fluorophore label, and so you read it under green by indirect immunofluorescence then. But again, like I've mentioned with a number of these antibodies, they don't just have one phenotypic presentation. So yes, you would find this in our stiff person spectrum evaluation, but we also have it in a number of other autoimmune CNS evaluations because it's pertinent to dementia, encephalopathy, seizure disorders, dysautonomia. And so it's, although it's a rare antibody, it's pertinent to all of those particular phenotypes. What about antibodies targeting glycine receptors? Well, mostly these are associated with, or have been associated kind of historically with this PERM phenotype, this very severe encephalomyelitis of rigidity and myoclonus, sometimes associated with thymoma as a paraneoplastic cause. But there have been reports of patients with other phenotypes. And so we looked at that in our lab, looking at our own stiff person cohort, and we found that indeed there are glycine receptor antibody positive patients with stiff person, classical, or maybe just stiff limb, a variant stiff person, as well as these PERM phenotypes. We found that glycine receptor antibody can show up in GAD65 positive or negative patients. And what we also found was that if you have glycine receptor antibody positivity, you're actually more likely to respond to immunotherapy than patients with stiff person that are glycine receptor antibody negative. So you could take from this that not only is it a diagnostic marker, but it's also indicative of potential for treatment response. And we've also done some studies looking at that glycine receptor antibody actually has functional effects in cell systems where glycine receptors are expressed. So not only is the antibody a biomarker, but it's also potentially pathogenic. And so that probably explains why these patients have such good responses to immunotherapies like plasma exchange. So we've covered a number of different neurological phenotypes already under movement disorders. So we have ataxia, chorea, dystonias, with Parkinsonism, which really kind of fall under the fall under the autoimmune movement evaluations, serum and spinal fluid, but then also an upcoming stiff person evaluation for kind of the spectrum of diseases under that particular umbrella. Then what about myoclonic disorders? Well, these are generally either a classical autoimmune phenotype called opsoclonus myoclonus syndrome. So that means myoclonus of both the extraocular muscles, as you can see here in this particular patient, or myoclonic twitches of the and myoclonic twitches of the extremities. So that's kind of a classical autoimmune phenotype. There really isn't kind of much of a differential diagnosis for that one. So if you see this particular phenotype, think autoimmune, either paraneoplastic or idiopathic. But then you can also have patients who will have just the opsoclonus on its own, or just the myoclonus on its own. So maybe whoever WF is, perhaps maybe turn your mic off, because it's just a bit of, yeah. Then what are the biomarkers of this? Well, there are a number of different biomarkers, antibodies that are important here, but a lot of these patients have idiopathic disease, meaning that they're idiopathic autoimmune. So they're autoimmune, but we don't know why. So it's not cancer related. But these are particular autoantibodies that are pertinent to kind of myoclonus. And again, ordering the movement disorders evaluation is going to kind of cover all of those opportunities, and you might want to order glycine receptor antibody as well if you're suspicious of PERM. So that kind of covers the phenotypes, and as you can see, as I've mentioned, there are diverse different antibodies associated with different autoimmune movement disorder phenotypes. There's overlap between the different phenotypes clinically, but also then overlap serologically in terms of antibodies being represented across different movement groups. Then there's also overlap outside of movement disorders. So again, where does this all fit in? Well, I think from a clinical perspective, it's okay. This patient has subacute onset of a central nervous system disorder where there is suspicion for an autoimmune cause for a number of different reasons. Maybe because either they got a classical phenotype, a well-recognized phenotype like limbic encephalitis, or there's other suspicious features like an autoimmune history or an abnormal MRI or EEG where you're thinking of autoimmunity. And then it's really down to, okay, what's the phenotype? Is this epilepsy? Seizure predominant? Is it encephalopathy? So kind of cognitive neuropsychiatric plus seizures, or a combination of those things. So encephalopathy, dementia, where it looks like kind of like a CJD or rapidly progressive dementia, like a rapidly progressive Alzheimer's, but autoimmune is in the differential diagnosis. Or is it a movement disorder? Is it a chorea, ataxia, dystonia, Parkinsonism, myoclonus? Then is the patient a child? That would be important as well, because there are certain antibodies that aren't pertinent in children. So you can take things like PCA1 off your list, anti-O off your list for a child, similarly with CRIM5. Or is this a kind of more of a rapidly progressive spinal cord disorder with normal imaging, or maybe symmetric T2 signal abnormalities down the cord that would make you think of an autoimmune or paraneoplastic myelopathy? So those are really the only other questions to ask. And then it's okay, that's the evaluation I'm going to order. That evaluation will cover all of the autoantibodies that Mayo Clinic has to offer pertinent to that phenotype. What if it's an overlapping phenotype? The patient has encephalomyelopathy. And so then you're kind of thinking, okay, how am I going to cover that? Well, you could order either or in that scenario. So we've built that into our considerations. The main thing is not to order two evaluations in the same specimen type. So you don't need a movement evaluation and an encephalopathy evaluation in serum in the same patient. So you want one serum evaluation and one CSF evaluation. There may be some other add-ons you'll think of, like maybe, okay, there's some stiffness here, and I'm thinking this might be a PERM phenotype, but I'm not sure I want to cover glycine receptors. So you'll probably order glycine receptor as a standalone in addition in those patients. So, what do we know so far? Well, I've kind of told you a lot about different antibodies, but this is kind of just to give you kind of a sort of a big picture sort of analysis of things. In our clinics in Rochester and also in our epidemiologic studies, if we took autoimmune encephalitis, half of our patients are seronegative. So that's just to show you how much we still have to learn. So this whole field is not going to get more simple, it's going to get more complicated. So that's another reason we develop these evaluations. So as time goes on, we'll find another antibody, and it may be relevant to encephalopathy only, or maybe epilepsy only, or maybe movement disorders only, but it may be applicable to all of these things as well, like DPPX is now. But again, we can drop it into whichever evaluation is going to be relevant to that. And the evaluations are very, they're varied in terms of how many antibodies are in there. Look at CNS demyelinating disease, 2 antibodies, MOG and aquaporin 4. Compare that to encephalopathy where you're dealing with, 15 or something. But maybe in time, there'll be more biomarkers for CNS demyelinating disease. Other point here is just to point out that, if you kind of consider, well, I'm just going to, patient with encephalitis, I'm just going to order NMDA receptor antibody only because the phenotype is so classic. That's okay, I guess, but you would have, you should be kind of thinking, well, if it's negative, I do really need to be thinking about other things here. So what about serum versus CSF? Well, I think for the most part, in general with our evaluations, there are some that only need to be tested in serum. like aquaporin 4 and MOG together. But then there are some scenarios like encephalitis whereby really serum plus CSF is required. Why? Because antibodies like GFAP, neuronal intermediate filaments, NMDA receptor antibody are more sensitively and specifically detected in spinal fluid. Whereas the opposite is true for LGI1 and Caspr2 antibodies, where they're more readily detected, not more specifically detected, but more sensitively detected in the serum. So in that clinical scenario, really kind of both are required. Then sometimes it comes up, should we be doing this consecutive or concurrently? I think for patients where there's a high index of suspicion, I recommend doing these things concurrently. For some scenarios where perhaps there's a sort of a broader differential diagnosis, and where most of the things you're thinking about might be covered in serum, well then you might be thinking about doing it consecutively. So what about treatment then? So in general terms, we're talking about trials of IV corticosteroids or plasma exchange. IVIG, if you can get it covered by some miracle, it seems to be readily coverable for stiff person syndrome, but outside of that diagnosis, it's quite hard to get that unless the patient's in a kind of a hospitalized environment. And then improvement with treatment might lead to further treatment and slow tapers of treatment, maybe transitioning to a steroid-sparing agent. Non-improvement, you could consider, well, if steroids didn't work, maybe we'll try something different. It's kind of beyond the scope of what I'm discussing today, but really the main thing to kind of take home from this is, time is brain, and so the earlier we treat patients, the better. And so if in patients where there's a high index of suspicion, we don't tend to recommend for test results to come back. We'll say, go ahead and treat, and then let the test guide you on some of the finer details. And here is my contact information. Why would you contact me instead of the representative? Well, I guess if you have a patient whereby you have a serum or spinal fluid coming through the lab, and you might be wondering, okay, what about an unclassified antibody? So you have all these antibodies that you showed us today that have very specific staining patterns, like say this one for DPPX. But what if you saw neuronal staining and it was a pattern that you didn't recognize, and you're saying, okay, well, it's a nervous system antibody, we know that, but all of our other testing, reflex testing, is negative. The staining pattern didn't look typical for whatever. Sometimes doctors want to know that information, and they'll call us up and say, or email us and say, any unclassified antibodies here, we're very suspicious for an autoimmune neurologic disease. And that'll give you kind of a little extra, the unclassifieds give you kind of an extra little percentage in terms of diagnostic sensitivity. The other point of those antibodies is that that's really kind of the basis for all our discovery work. So say, for instance, the septin-5 that I showed you today, we discovered that through identifying that staining pattern, getting the history, but then seeing the same thing in 5 or 6 other patients, and then realizing, okay, we got the same staining pattern on tissue, the same history, let's go find what the antigen is, find what the protein is. And so that's the basis of a lot of the work that we do here in research. So that's all I have. I'd be happy to take questions. Thank you.